Welcome to Season 5 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former health commissioner here in Baltimore, Maryland. Our goal with this podcast is to bring scientific evidence and experience to shed light on critical health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, it's a special episode of the Public Health on Call Book Club. I speak to Dr. Lisa Cooper, a Bloomberg Distinguished Professor at Johns Hopkins and the author of a new book entitled Why Are Health Disparities Everyone's Problem? In this book, Dr. Cooper tells the story of her own pioneering career understanding and addressing health inequities. Let's listen. Dr. Cooper, thanks for joining me on Public Health on Call. And more importantly, thanks for writing this book, which is called Why Are Health Disparities Everyone's Problem?
Thanks for having me.
So I want to maybe start with a step back because you are a national leader in the field of health equity. And your story is truly remarkable. So, the field has really come along with your career in a way. And I think it would help people to understand where that career started.
Sure, yeah. So, my career, I guess, started here in the United States when I went to medical school. But really, when I think about it, the ideas that have shaped my career began, in my childhood. So I was born in Liberia, West Africa. My parents were professionals. My father was a physician there, and my parents worked together to establish a small hospital there called the Cooper Clinic. And that clinic provided care to people in the community, regardless of their ability to pay. So I think I saw my parents, working together. Even though my mom was a university librarian, she really worked alongside my dad in running the hospital, the small hospital. So we were, the whole family was part of that. And, I even spent summers working there at the clinic. And so really saw my father working on helping people who were sick from all walks of life. And I saw young children who had problems that, had been delayed in being addressed because their parents couldn't afford healthcare. And a lot of them lived in conditions that weren't as nice as where I lived. So I knew they didn't have the same opportunities I had. So I think I was really aware of how our life circumstances affect our opportunities to be healthy from the time I was pretty young. And I really wanted to work in that field. I wanted to become a physician. I wanted to work with my father, but I didn't really know what the words were for what I was seeing at that time. But it really turns out that it was the inequities in our society that actually led to some people having a great life like mine, where we went to great schools, and my brother and sister and I, and we all got our vaccines on time. And if any one of us got sick, we had a doctor. But there were so many people around us who didn't have those same opportunities.
And, from that relatively advantaged background, you moved to the United States, totally, across the world. What was that like, and how did that affect your growing interest in this area?
So, I moved to the States. It was something that I expected to do because I always thought I would come to the U.S. to pursue like my higher education, college, medical school, but I always had the plan to go back home. But what happened right before I left Liberia was something that really changed, I think, the whole trajectory of my life. And so there was a coup where the government was overthrown on my 17th birthday. And so, I didn't just leave and come to the States for college. My whole family was uprooted, and we actually were targeted by violence from, other people in the country. And in fact, lots of people who were from sort of upper middle class or more advantaged groups were targeted during that coup. And a lot of it was because there were, inequities and lack of social justice in Liberia. So I think that it brought that issue into sharp focus for me. So, we left kind of under those violent circumstances. And even though I was coming to college that year anyway, my whole family left. So when I came to the States, I, of course, like any young adult, I wanted to just be a young adult. I wanted to go to college and just kind of do what I wanted to do. But always in the back of my mind was, what was I going to do that would help to make a difference back in Liberia? But at the same time, I was noticing that there were a lot of issues in the United States where there were a lot of people who were definitely much healthier and better off than other people just across town. So again, that problem was something that I was like more acutely aware of, and continued to focus on when I got through medical school, and then moved to Baltimore, where it really made me realize that, people in Baltimore were struggling with a lot of the same issues I had seen in Liberia, with poverty and, lack of housing and good employment or education, and lack of health care.
And at that time, you decided that you would start to study that. That would be the focus of your studies. That wasn't very common at that time.
No, actually it wasn't. So when I left residency, where I had seen a lot of this playing out in caring for patients, in the emergency room and in the hospital, and came to Hopkins to study public health, because I thought I was going to do public health practice, probably. I didn't really think I was going to do research. But what I found out is that the problems I was interested in addressing, that there was not always a lot of data on those problems. Like nobody was actually studying those issues. And so when I said that's what I wanted to study, a lot of people around me said, well, that's all fine, but it's not really a problem that's of general interest. So why don't you do it as like sort of a side interest or a hobby, but find something else that's kind of more important to everyone.
Well, I'm so glad that you did not. And maybe, you could talk about, I know you got some initial support, I believe, from the Robert Wood Johnson Foundation.
Yeah, so I said to people who said that to me that, well, I'm going to continue to study this problem because this is what I think is important. And I think it's actually pretty important and affects a lot of people. So I did apply for funding to the Commonwealth Fund, Foundation in New York, and then also to the Robert Wood Johnson Foundation for career development funding, because they had a special program that was designed to attract people from underrepresented groups in medicine into research. And so I applied there and did get funding, and focused my initial work on disparities in care of depression. Disparities in the way of like racial disparities, because I had seen a lot of African-American patients coming in with complaints, kind of physical complaints, headaches, fatigue, lack of energy, and getting sort of a whole bunch of different tests done before it became apparent that they actually had depression or anxiety. So I wanted to focus on that.
And you learned a lot about how doctors and patients interact, including across racial lines.
I did, so when I studied the patients with depression, I asked African-American patients about their experiences in the healthcare system and what made them seek care and what made them actually accept treatment. And I did the same for white patients. And I found that patients across the board said that having a physician who actually listened to them, treated them as an individual, cared about them, and then was someone that they felt they could trust, was somebody that they would be most likely to seek care from for depression. And then there were some differences between the groups where African Americans tended to be more concerned about issues related to spirituality and its role in depression, and the fact that that was, oftentimes not addressed in their care. And then they also expressed more concerns about antidepressant medications were addictive or were just covering up the problem. So I started looking at differences in patient experiences, but then also I really wanted to focus in on the role of the patient-physician relationship, because it seemed like that was so important to everyone. But yet and still, there were issues where a lot of African American patients in my studies expressed concerns such as lower levels of trust in physicians and, feelings of being like treated disrespectfully, things like that.
And some of your most groundbreaking work was actually recording patient visits and looking at whether those concerns were correct, that doctors were treating patients differently.
Right. Initially the studies were based on surveys where people reported these experiences, but the question was always, well, what really happened? Because if you ask physicians, they would report one thing and then patients would say that they had experienced something else. So I really wanted to get into that black box of the clinical visit. And so I worked with one of my colleagues here at Johns Hopkins, Dr. Deborah Roeder, who's a world-renowned communications researcher, but who hadn't really focused primarily on the issue of race or differences across race in doctor-patient communication. And we measured those communication behaviors by actually getting permission from doctors and patients to record their visits. And lo and behold, we uncovered that what African American patients were reporting did sort of bear out in some ways because doctors tended to dominate the conversations when they were seeing African American patients, and African American patients weren't talking as much or asking as many questions as white patients were.
This entire area of how you actually build trust and how important trust is for patients to be able to get the care that they need, is really come into its own during the pandemic, because we've seen that people who don't trust won't get vaccinated, and that puts them at risk, their families at risk, everyone at risk. But back when you were doing these original studies, this whole area was really marginalized within academic research.
It was, I think a lot of behavioral research overall tends to be more marginalized or used to be in medical research. People tended to focus more on the technical aspects of care and really to think that things like the way doctors communicate or the way patients feel when they leave a visit are just softer things and harder to measure and quantify, and that it wasn't the same as, for example, looking at whether a drug worked or whether a specific type of surgical procedure worked or not. So that was an uphill battle.
Yeah, so important. And as your career progressed, you have also looked at some of the social issues that affect patients outside of medicine altogether and the impact of those issues on health.
Absolutely, because we know that a person's race or ethnicity is nothing. It's not a biological measure of health. It's really sort of something that is a marker for other life experiences they may have. And so we know that in the United States, African Americans and other people of color live in communities that have experienced economic displacement, and they've been exposed more to discrimination in this larger society. So we know that patients from those communities bring into those visits with them, they bring those experiences, and some of those barriers that they face outside of healthcare influence what they are able to do and what they're willing to disclose to physicians.
Now, in addition to your groundbreaking research describing these problems, you've also done work on solving them. Could you talk about that a bit?
Sure. So, my early interventions work focused on empowering patients to be more involved in their care and to ask more questions. And then also in training physicians to be better at listening to patients' concerns and being more aware of some of the social and cultural factors that were shaping their healthcare. So in that study, we actually intervened with physicians and had them go through a training course that was an online feedback on how they were performing with their African American patients. And then we had community health workers who acted as coaches to the patients. And these patients had hypertension, and they met with a community health worker and were trained on how to ask questions and how to advocate for themselves when seeing physicians. And we saw that when we combined those two programs together, that we actually ended up achieving better blood pressure control among our patients. And those patients actually reported being more engaged and activated about their health. So that was one of my earlier studies. And now we're doing studies that actually intervene on multiple levels. So not just patients and physicians, but also other care team members, and also on the leadership level, training health system leaders in how to use more of an equity addressing their organizational practices.
I wonder, where you've seen successes and how you keep your motivation going when we're talking about problems that really have hundreds of years in the making.
Yeah, I think that's a question I get asked often. Is like, what keeps you getting out of bed every day and working on this? And what I'll say is it's really the people that I interact with. It's the patients that I see, because I still do see patients in clinic that remind me of why I'm doing this work. And the family members. It's the physicians who I see working so hard to deliver care to these patients in their communities, who are so committed to delivering the best possible care they can, but are working in some very challenging situations, and oftentimes with lack of adequate staffing or support to do it. So that we know that the disparities that we see in care are not because, for the most part, that people are intentionally treating people of different racial or ethnic backgrounds differently, but that there are really challenges in delivering care to these populations, and that we also, as physicians and other health professionals, bring into our interactions our own biases and our own perceptions of what who people are and what their problems are and how they should be solved. And so we have to work through all of those things. So I think what really keeps me going is those interactions with people, also with my community partners, people who lead these community-based organizations that deliver services, whether it be helping to connect people to housing or food. It's the community health workers who go out there every day and check on people at home and make phone calls to them. And like I mentioned before, the staff members, and then it's my colleagues in public health and research who are also similarly committed to this work and to changing the lives of other people. So making sure we're using the best possible science to inform our decisions.
In the book, you quote the former U.S. Surgeon General David Satcher, who wrote, "We can achieve health equity in America, but first we must all care enough, know enough, do enough, and persist long enough."
Yes. I think those words have inspired me and re-inspired me when I sort of wonder, like, how do I keep doing this, or how do we keep doing this? Because it feels like, so little progress has been made over the course of my career. But then when I look back at the fact that people weren't even talking about this back then, and that it's now something that lots of people are talking about, whether it's in the media or whether in the political realm, and even in the halls of academia and healthcare, then I know that we have made progress.
Now, the title of the book is "Why Are Health Disparities Everyone's Problem?" And, in a way, the arc of your career is, you were one of the only people studying this. And now there's a lot more recognition of the serious divides that exist in our society, how they're reflected in health, and even in some ways, some momentum for serious policy change. And I know you're on the White House Science Advisors Advisory Committee talking about these issues. What's the case that you make for why health disparities are everyone's problem?
Well, one of the cases I make is that, as we've seen very clearly with the COVID pandemic, that health inequities harm everyone. And that's because we are all interconnected. Our health is interconnected. We've seen that if one group of people is more likely to get sick, that it does actually spread. When in the case of an infectious disease, we've seen that if someone is a frontline worker and they're taking care of someone, a family member in a nursing home, for example, we've seen that if people from that community become sick, that others can become sick as well. So I think that's one argument I make. And we saw actually how our whole economy came to a standstill. So a lot of our frontline workers were from these higher risk groups that were exposed to COVID at higher rates, and then we're no longer able to work, and our businesses shut down and our schools shut down. And, so that's one case I make. And then on the flip side of it is that when we have health equity, it actually improves conditions for everyone. So that there are actually solutions that we develop that may be designed to improve health for one group or for a more vulnerable group, but that particular thing actually ends up benefiting everyone. So for example, the Affordable Care Act is really designed to provide health insurance to people who couldn't get it through their work or some, other mechanism. Having that available benefited everyone because when other people who weren't in that category became at risk or lost their jobs, they were then able to access that, right? The other thing I say is that, when there's an equity in society, because I've personally experienced that, we can get a lot of social unrest and conflict in our society. And we saw that play out with violence that was perpetrated against Black men and women by police and through the Black Lives Matter movement, that there was less social cohesion during this time. And a lot of that is due to inequities that we have in our society and where people don't have opportunities to live the healthiest life that they can live. So those are the main arguments I make, that I actually think when we have health equity, we are all stronger, our economy is stronger, but to achieve it, it doesn't mean that we give everyone the same thing. We need to look at the unique needs of different groups in our society. And if we want to have a higher standing in terms of health, in terms of leadership, global leadership, or whether it be in science or in business or economics, we've got to have a healthy population. And if we have a substantial proportion of our society that isn't healthy, we're going to lag behind.
A component of your vision in this book is herd immunity, but not the herd immunity from just an infection. Could you explain that a little more?
Sure. Yeah. I wanted to use that metaphor because I think people were hearing a lot about getting the vaccine distributed and making sure that everyone had herd immunity from COVID, that, so many people could be protected by, if we got a majority of people in our country protected, then it would protect everyone, right? But I wanted people to remember that herd immunity is not something we only need against biological factors, but we also need to think of herd immunity in terms of people having their basic needs to live a healthy life met. So everyone having access to safe housing, to healthy food, to a good education, to a safe place, to basically, exercise or have recreation and employment opportunities. So if we could think of herd immunity more broadly, if we are protecting ourselves from those negative social factors that really shape our health as a group, then we'll be healthier overall as a society.
Well, Dr. Cooper, thank you for everything you do to make that vision a reality. And thanks for joining me today on Public Health on Call. The book is called Why Are Health Disparities Everyone's Problem? It's really terrific.
Thank you, Dr. Sharfstein.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Niall Owen McCusker, Matthew Martin, Spencer Greer, and Holly Cardinale, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holz Fernandez. Thank you for listening.